Good morning. Welcome to those in the room as well as those on Zoom. Very excited this morning for our 2025 Spring Geriatrics highlights. And it's going to be different than what you expect, but I think you're going to love it even more. So just a few announcements. The next grand rounds is in 2 weeks. Casey Johnson, Mind the Gap, closing medication gaps and transitions of care. So we have a total of 3 grand rounds in May. This is the first one, so continue joining us for a few more after this. We will also have Journal Club this month, or no, Jacob? We know that there is no Journal Club. Some of us will be at American Geriatric Society next week. So there is a division meeting following this grand rounds this morning, so please stay for that if that applies to you. We don't have evaluations today, but certainly we hope for engagement with questions and kudos and following ongoing conversation. So with that, we have 5 different people presenting today. Historically, this has been American Geriatrics Society highlights. I broadened it because it's speaker's prerogative to broaden it. And so we will actually have a diverse group today, including Emily Larson presenting highlights from the American Physiology Society and Stephanie Hartz presenting from the VA related to an abstract that she and colleagues presented at another local meeting. So we will kick off with Thais Protasio. So in total, we have 5 individuals who will be presenting highlights. I'll keep time. They'll have about 10 minutes each, really desiring to have some time for questions and answers. We've set this room up really well that the microphones in the ceiling will work for the people on Zoom, which will also mean that we'll be able to have a nice flow of Q&A. So Dr. Protasio.
Hello, everyone. Good morning. I'm happy to be here and in May, almost done with fellowship, and to present the works that I've been doing for this past year. So I'm going to start with this first project that I've been doing oriented by Dr. Lum. This is a qualitative project in which we wanted to listen to the voices of Hispanic Latino caregivers of patients with dementia in the knowing that this population really face health disparities and that palliative care models may not be culturally sensitive to them. We wanted to understand their barriers and struggles to be able to guide us on future palliative care interventions. So for that, we have 3 virtual meetings in Spanish facilitated by bilingual researchers. They were done both here in Colorado and in Boston. We had this large research team involving people here from Colorado, as well as researchers from the University of North Carolina and from Mass General. And with the meetings, we're able to partner with 11 Hispanic Latino caregivers. They're all family members of patients with dementia. They had different stages of dementia, the patients, and 9 of them were women. They had different levels of education and occupation status, and came from different countries in Latin America as well as Puerto Rico. And we have so much information, so I'm going to focus on some of the ones that I thought were more kind of pertinent for us to guide the interventions in the future. So one of the things that the caregivers mentioned was that they saw caregiving as a responsibility. It was something that they wanted to do, but it also came with stress, anxiety, and guilt. And they felt like they received a lot of support for their loved ones, but not enough for support from themselves. They really wish they had received, the providers could ask them more how they were doing and offer more mental health support. So something that we should think about. A lot of them also mentioned that they wish they had received more education on dementia. That was really a big barrier for them to self-educate on the stages of dementia, on what to expect and what to do as caregivers. And they wish they had received more information from the provider. Maybe some of the suggestions were meeting with the provider separately or having education sessions that should be held outside of working hours. members that would be helpful to them. They also said that they received a lot of resource lists and guides, and that sometimes it's not really as productive as we think it is. They can be very hard to navigate. Sometimes when they call the resources, the staff doesn't speak Spanish, so that can be very hard. And they wish they received more information from the providers themselves. So they say it's very important to ask people to have people to ask questions to. And they mentioned the PCP, the neurologist, the social worker, and the guide program navigator as very important source of support. They also say that for themselves, they have faith, religion, and family as big sources of support. And there is a barrier when the doctors don't have kind of the same beliefs, or they only trust in science to make their decisions. So they wish they had more open conversations about their beliefs to be able to guide their decisions that they are making. Another cultural challenge is when they don't really see nursing homes as an option, and this is something that we tend to offer more than they would like. Finally, they also say that it is important to have end-of-life discussions. They recognize that these are very hard conversations, and they prefer to have them with providers that they have already a relationship with, but it's hard for them to think about these things, so they think that the provider should be the one to really broach these conversations, and wish they did it more. So really also things that we should think about. A lot of more information, but because of time, I'm gonna pass to the next one. Okay. My next project is actually very different. This is a quantitative study oriented by Dr. Kenny Lam. And for this study on income, wealth, and chronic disease burden in older adults in the US and Brazil, we come from the idea there are actually many recent studies showing that low socioeconomic status is closely related to disease, morbidity, and mortality. And this relationship is actually more significant in the US than in other countries around the world. The thing is, we don't have as much information in comparison with the US, comparing with middle income countries such as Brazil, where I'm from, for those who don't know. And we don't really have an understanding of why this happens and why the United States is in disadvantage. So for this study, this is a cross-sectional study of adults aged 50 years and older using two nationally representative studies, the health and retirement study from the US and the Brazilian longitudinal study of aging. We did survey-weighted log nominal regression to see the association between income divided in percentiles and chronic disease, self-reported disease, self-9 reported diseases. And the analysis was adjusted by sex, age, and education. As you can see here in this middle figure, this middle graph, the association between low income and chronic disease was more significant in the United States, as you can see in the blue line, when we compared it with Brazil with the yellow line. Statistically significant with a p-value less than 0.05 in most of the diseases, apart from dementia and cancer. And to understand that further, we performed multiple sensitivity analysis. So we actually repeated the same results with wealth, and we found very similar results. So we didn't include it here. To understand why this happened and if this association was mediated by healthcare access, we did a mediation analysis, and we didn't think that this relationship was really mediated by healthcare access with an ACME or less than 0.02. Finally, we wanted to understand if, because most of our results were self-reported, we wanted to understand if recall bias was really playing a role. So we also analyzed objective hypertension data. We had blood pressure measurements from the surveys, and we compared the objective hypertension data with the self-reported hypertension, and we found very similar results on both, with the same kind of relationship between income and hypertension, kind of saying against the recall bias. And then to understand if we're dealing as well with survivorship bias, we evaluated mortality data with a later wave, of the surveys. And we didn't see any difference in disease-specific mortality between the countries with a P more than 0.05. So with that, we conclude that the economically disadvantaged older adults in the US are facing higher disease burden than in Brazil, with a higher higher health disparities. And we can't yet explain this relationship. Doesn't seem like it's related to healthcare access or mortality. So this is further work to be done. And this is all I have. Thank you.
We have about 2 to 3 minutes for questions. Yes, Josh.
Is there a obesity difference in older adults between US and Brazil? Because a lot of these diseases I see that are more prevalent in the US are obesity driven.
We didn't really adjust by BMI. I'm trying to think about other studies that did, and they didn't really see a difference. So maybe I'm going to say that there may be a difference, but I don't think that has been really being able to explain things before.
Other questions, and please speak up so that the ceiling hears you.
I have a lot of questions, but I don't know where or what to ask. One thing that comes to mind is looking at annual income and wealth. Is there, or did y'all consider like a cost of living adjustment and geographic differences within the US and Brazil?
We didn't in our analysis. I know there are kind of studies in Brazil that have looked into that, and they also see kind of these differences between regions to also play a role in disease burden. But between countries, we didn't really look, and Kenny may have a different opinion.
We used income percentile and wealth percentile to basically just look at relative comparisons. And so that was how we tried to get around this. The cost of living adjustments would,
That'd be,
not specific.
yeah.
Thank you.
All right, I will invite Dr. Bellantoni up to the presenter, please.
All right. So this is a poster based off of a project I did with Dr. Runkle, as well as some colleagues in the Department of Emergency Medicine, on a provider survey of the geriatrics consult service in the emergency department. So by way of background, I think a lot of us know the geriatrics consult service was started at the university emergency department in November of 2023 by Dr. Runkle and Dr. Bolin. And at its beginning, the service itself saw seniors clinic patients in the emergency department during business hours, regardless of complaint. So they were seen by Dr. Runkle or Dr. Bolin if they presented to the ED. And when we think about program evaluation, I think as geriatricians, this is something we all see as very beneficial, but it's important for us to understand what is the perspective of the emergency department providers on the consult service. So the aim of this project was to assess their experience and satisfaction with the geriatrics consult service. To do so, we created a 10-question survey within REDCap and shared it with ED providers. It was both in paper form and electronic. We went down to the ED and actually handed them out, as well as created QR codes that we shared with the providers. They put it up in the break room. It was disseminated in emails as well. And the survey itself asked a number of questions assessing provider satisfaction with the service, the frequency that the recommendations change the treatment plan or the disposition for a patient. They asked about the most useful geriatric consult service. And then finally, it asked about ED provider comfort with various geriatric syndromes. You can see, I think, just a snapshot of some of the questions on the right. For analysis, we generated descriptive statistics, and I'll show you expressed as percentages. And then to understand what were the most useful consults, we performed a weighted rank order analysis. We received 47 total responses, about half of which were from attending physicians, 19% from resident and fellows in the ED, and then 30% from APPs. Based off of the number of ED providers, we estimate this is about a 28% response rate. 96% were satisfied with the consult service overall. 94% were satisfied with the availability of the service. 13% said that the consult changed the treatment plan or the disposition for the patient. And 91% said they'd like to see the service expanded. When we looked at what were the most useful consults for the ED providers, the top three, first was assistance with care coordination and disposition planning. Second was helping manage dementia with or without behavioral disturbance. And then tied for three actually was medication recommendations, as well as goals of care conversations, including palliative and hospice care. And when we assessed what were the level of confidence that the ED providers felt with various common geriatric syndromes, we ranked these 1 to 6. At the top, they were most confident with falls and frailty, but reported less confidence with things like hospice and polypharmacy. One of the most striking responses or sort of feedback I think I received from the survey was actually just a free text. So the last question said, is there anything else you'd like to share with the service? And there was quite a lot shared for ED providers, I think, in terms of their responses. And I wanted to highlight just a few of the quotes I found powerful. First, and I took out a lot of pleasantries in the other quotes, but these were all over the responses, that the geriatrics team is amazing, and I love when I see them come to the ED. Their care, attention to detail, and expertise is incredible and helps us provide better care for our geriatric patients. They're at the bedside fast and spend enough time with the patient to understand their goals and help to establish disposition. They can greatly help keep patients out of the hospital. They have significantly improved the care of geriatric patients in the ED and help facilitate appropriate outpatient dispositions of patients who otherwise likely would have been admitted. I love to discuss my thought process with someone who has a geriatric point of view and can help me with my own blind spots. Also, someone who knows the patient and family already is so helpful to talk with. Amazingly helpful and with med management and long-term care, really helping keep our elderly folks home and getting difficult histories. And finally, it makes us feel more comfortable discharging them, knowing a physician is aware of the condition and can closely follow as an outpatient. And while we did not conduct any formal qualitative analysis of these comments, some general themes that pop up to me is that as geriatricians, we have a different lens and approach to care. We can dedicate time in a different way than our ED colleagues to considering the care trajectory, the bigger picture, especially transitions of care and disposition planning, but that we're really a complementary service to how they take care of their patients. And I think these quotes say a lot. So in conclusion, the consult service was well received by ED providers and is most useful in care coordination, dementia management, medication recommendation, and goals of care. In considering next steps, first, I think it would be interesting to conduct some qualitative analysis of the survey responses, or at least gather more information and feedback from the ED providers. I think when we just ask them, what do you think of the service? How has it benefited you? The stories they tell are quite powerful and help us really consider what the utility of the service. And that leading, I think, very much into program expansion. So as we open up the consult service to beyond seniors clinic patients, we have to figure out who benefits the most. Where can we have our greatest benefit for the ED providers and the patients they see? And so part of that is focusing on what are the specific consult questions like polypharmacy, dementia management, care coordination that we can really help with as we try to promote more ED provider initiated consults in the future. And that's it. I'll take questions.
So I did get confirmation that people on Zoom can hear us in the room. Also, anyone on Zoom, if you have a question or a comment, feel free to put it in chat and we can see. Jacob.
So you got rave reviews in these surveys, but only 13% of respondents felt it changed the treatment plan. I'm curious if there was a stark difference between those 13% who felt it changed in the other responses. Was there a difference between the who felt it changed the treatment plan and those who didn't?
Good question. So I also at first was like, oh gosh, they say 13% only changed. But I was talking to Josh about this actually. He's like, well, I don't think that's necessarily a negative thing, that we're all trying to get to the same end goal, but that we're able to assist them in doing so. That's one positive outlook, I think, in approaching that answer. I did look at, though, like the 7% who were not satisfied with the service and looked at their responses. One point that came up that I think is well taken is that this as we started the service was an automatic consult, not a provider initiated one. And that's very dissimilar to how every other consult occurs in the emergency department. So those providers who were less satisfied with the service said, I want to consult you when I have a question because otherwise I feel like things are too scattered and I want to work together. So I think that's those were the people I think who maybe felt we did not have as much benefit.
Yeah, great presentation. I know nothing about this, but I'm just curious. Did you see a difference in like maybe who were not satisfied? Was it attending or see more attendings or resident fellows or by APP? Recognize the numbers are small there, but
Yes.
did you see like any results that you see the same group popping up who either made you better or worse?
Yes, I'll have to look more at that to give you a precise answer. I can tell you from looking through the data to see those that consistently answered the survey, dissatisfied and provided feedback, such as, hey, I want to consult you only when I have a question. Those were attending physicians. Maybe not so surprising.
I would just add the changing is one thing, but that didn't include care coordination, right? And care coordination, of course, is a huge part of things. So it seems like there could be another domain.
Yes. And on that note too, I think the medication recommendations we make, which is a big part, I think, of what we provide in the emergency room as our recommendations, those are the things that the ED providers don't see changing. And maybe it doesn't change disposition, but frankly, the treatment plan long-term, it absolutely impacts. And I think as they took the survey, they probably saw it more, did we admit or not admit the patient? And that has how they answered the question. Thank you.
Yep, great. Now I would like to welcome up Dr. Runkle.
Hello, you get to hear a little bit more about the ED consult service. Ellie could not be here. She worked on this project, but I'm presenting on her behalf. She is currently on DH wards in her final stretch of residency. So she did a project on trying to identify characteristics of avoided admissions achieved through our consult service in our university ED. So we established this in November 2023, as you guys know, and the goal was to reduce admissions for older adults, specifically seniors clinic in this cohort. So she looked at from November 2023, when we first started, to October 2024, so a full 12 months. And out of the 524 patients that we saw, 24 patients avoided admission. This is a very specific cohort of people because this is patients that went from a pink identifier in the ED on their track board, which is sort of, it's like a triage, discharge, expected to be admitted. They changed the color on the board. And if we as a consult service team was able to change that color from pink, which is expected admission, to discharge home, then we counted this as an avoided admission. So it's a very specific cohort, and there's potentially more patients that avoided an admission, but that's trying to be very specific about that criteria. So Ellie went through and did some thematic coding to try to group these avoided admissions into specific cohorts. She also looked at demographics, the presenting symptoms diagnosis, how they were discharged, time to follow up, and time to return to the ED. So this is their chief complaints when they came into the ED. So life-threatening to hospice was our largest cohort. That means basically like critical surgical emergency, critical medical illness, meaning severe symptoms that could not be managed otherwise besides admission, or other, severe sepsis, other things that would cause admission and actually transition to hospice after goals of care discussions. Hypoxia came up as in a multitude of cases. Dementia-related, falls, volume overload, arrhythmia, and stable chronic condition, which basically Ellie categorized as actually they were kind of at their baseline, but didn't know what else to do. And so they came to the ED. And then she did have this other category where they didn't really fit into any of one of those categories easily. So sorry, the pie chart is maybe a little small, but these are reasons discharged from ER, meaning what we were ended up being able to come up with to avoid an admission. So chronic and stable condition, again, if they kind of came in with their baseline condition, we were able to do a chart review or even talk to the PCP and say, actually, this is their baseline. One really easy example is hypoxia. There's multiple cases of actually they're at their baseline. And I was able to do that through chart review and looking through their past discharge summary, things that the ED attending doesn't have time to do. And sometimes can honestly be hard to verify with the patient. They say, oh, I'm not supposed to be on oxygen. And if you retrospectively look, they actually should be, but they choose not to be. So things like that. Risk of admission is greater than benefit, meaning high concern for like maybe a mild symptom or mild condition that the ED wants to admit the patient for, but ultimately with a, for example, history of dementia with a UTI, concern that that's a higher risk admission than the benefit of doing so. Again, patient at baseline, similar sort of theme as the chronic and stable condition. Admission not within goals is a large proportion and similar to enrollment in home hospice. So though 17.9% were actually admitted to hospice versus the admission not within goals did not go to hospice, but all within the same idea of a goals of care discussion. Essentially, the patients that say admission is not within goals, it's a goals of care discussion that Josh or I have saying, is this actually what you wanted? And unfortunately for a lot of our patients, they don't know where else to go if they have symptoms. They don't necessarily know about our acute care clinic or that they can call clinic and get in pretty quickly. And they end up coming to the ER. And so being able to take a step back and say, look, this is a choice. Do you actually want to be here and stay overnight? Which is frankly not a question that the ED really asks typically. It's not really part of their workflow. Although I will say, I do think there's some culture change or residents have been asking more and more. So I think that's a great thing that has changed that's hard to quantify. But that's that piece of the pie. And then adequate treatment available at home was things like antibiotics or diuretics, things that we were able to manage with, fortunately, very close follow-up with seniors clinic that didn't necessarily need to be admitted. The age of the cohort that was able to be discharged was age 77 to 99, median of 87.3. Most were women and most were white. So she also looked back at when patients came back to the ED. So, right, if we avoided admission and then they come back the next day, that's obviously not our goal. So the 7 of the 24 did return to the ED for various reasons. So a large proportion did not in the, when she looked back. A lot of these patients, a decent proportion of these patients did end up going to hospice. So they fortunately did not return to the ED for that reason, or we were able to get them into clinic really quickly. Time to ED return ranged from 6 to 107 days with a median of 16 days. So one patient in particular I can think of had kind of a chronic stable condition and we were able to recommend discharge home. And then she unfortunately ended up coming back. But now subsequently after 6 months of work doesn't come back to the ER as often now. So a success in the long term. And a patient's not discharged to hospice, outpatient follow-up time range to 13 days, from same day to 13 days with an average of 4.4 days, which I think speaks really highly of our seniors clinic and our access to care and acute care clinic. I appreciate all of you guys for participating in my ED follow-ups. I think it makes a huge difference. And there's actually very strong data that close PCP follow-up in geriatrics really does reduce ED admissions. So it is a care coordination aspect of my job, but I do think it really makes a big difference for our patients. So appreciate all of you guys for doing those close follow-ups. Happy to take any questions.
Questions from the group or on Zoom? Josh, you're up.
I have 2 questions and I am 100% naive to this field and patient care in general. For older adults in the ED who are pink status and haven't yet been seen by an attending or whoever they get seen by, how many of those would actually be admitted? Or how many of them transition to not status?
It's a great question. I only have anecdotal evidence for that because the sort of ED status isn't something that I've seen published in the literature, as in like they were expected admission status to discharge. That's not really reported in the literature that I've found. Anecdotally, I will say once they're turned pink, like they are going to get admitted. There's very few times really, if we get consulted or palliative care social work gets consulted, that's the few times that I see that it gets changed. The thing that's interesting as a medicine resident is you'll sometimes go down to the ED and say, I'm your doctor for your admission. And the patient actually has no idea that that's the plan. So unfortunately that does happen, not infrequently. And I do think that, fortunately, I do think we've had some culture change with that. But I would say anecdotally, it's almost 100% in our ED. We are trying to do a bigger evaluation of the data of our avoided admissions to get a little bit from a control group to our cohort to actually get some real data for you. I don't have that for you today, unfortunately, but hopefully next year you'll hear that presentation.
And I think the reason I was asking is, we're in a time of budget constraints
Mhm.
and thinking of cost avoidance. And so if you have a solid control group and you can demonstrate cost avoidance, I think that's a really powerful thing to look at.
Yes, definitely. That's definitely absolutely a piece of the puzzle and pie that we're hoping to present on. I think right now our hospital system is frankly often in a state of crisis in terms of volume overload, and in even having to divert care, which is a huge cost to the system. And so the ED team, our team, and I think hospital wide is very interested in this topic to try to avoid unnecessary admissions and elevate goals of care in those conversations, because if a patient doesn't want to be here, we shouldn't fill a bed with that patient. And especially in geriatrics, it's often not for their benefit anyway. But I was able to present to the Department of Medicine in 2023 on this project, and they were excited enough about it that they supported it. So I think there's a lot of interest in avoided admissions and cost savings for sure.
I don't have a question. I have a comment about cost avoidance. I think the challenge with that is that locally, like us avoiding the cost of that admission actually makes the hospital less money. And so, and we, like you said, the hospital has other incentives for not admitting people because we're always over full. But in the scheme of the world, the people who care about that are like Medicare insurance companies. So, that's always a challenge. We met with Trinsic, which is complex, but essentially like a Medicare cost savings plan. And they like have potential interest, but I think it's hard because like where the funding would come from the cost savings doesn't always correlate super well with who we can actually talk to and make plug to. Zach.
Curious on the way you stratified your patients for the reason they entered the ED initially. It seems like a patient could theoretically fit in multiple categories. So did you consider the interactive effects of the reason they entered the ED in your subsequent analyses?
Yeah, it was, so chief complaint in the ED is usually a singular statement, which is flawed, absolutely. But for the convenience of this, they do actually type in the nurse like triage note, and in the ED like initial note, they do have a chief complaint. We also put a chief complaint in our consult note. And so I think Ellie used all of those pieces of information to combine into one singular complaint. But you're absolutely correct. People do not fit in an easy box, but we end up charting that way, for better or worse.
Yeah, thanks.
This work reminds me of some of the other work published around Geri ED accreditation, where they looked at, some of these other numbers like time in ED, time to infertile, so these process measures, but then also historical data or run chart data to basically examine, was there a change? That's where you're thinking of going?
Yeah, absolutely. So we have a huge data set that is pulled from Epic. We have time to consult, et cetera, et cetera. So TBD, like to be continued. Hopefully next year we'll be presenting that data. Lots of analysis to come.
I'm curious about the conversations that transitioned into hospice and our palliative care social work team, and just like about that relationship, because I'm just struck by the majority. It seems like there's medication management, obviously, but also a lot of palliative care, patient care discussion as a part of that geriatric consult. I'm just curious about that relationship you have there.
Yeah, it's really amazing to have them as a support. I usually, as soon as I get the feeling that the patient really doesn't want to be admitted, but they're pretty critically ill, I message one of the palliative care social workers and I'm like, can you come in? And we'll have like a shared goals of care discussion, somewhat modeled off of what I saw when I rotated with the palliative care team as an intern, and trying to use that partnership to balance the goals of care discussion, because it can be really a difficult conversation to have in the ED, right? You're like sick enough to be in the ER, you came here seeking care, and suddenly we're making this massive shift. And so it can be a pretty long conversation. You need to get all interested people involved, so we're all on the same page and can have a meaningful next step that everyone agrees on. So it's been a really amazing partnership. They do such a good job, and I think they enjoy working with us too, because we have the doctor backup voice to potentially give prognostication information, which they, don't step out of that boundary for their social work role. So I think it's a really amazing relationship.
Yeah, thanks, Kate. I'll welcome up Dr. Larson next.
All right, thanks. So I am just going to be sharing some data that I presented at the American Physiological Society Summit last week as a poster. All right, so we know that high systolic blood pressure is a major risk factor for the development of cardiovascular disease. And there's also some evidence to suggest that in women, the increase in cardiovascular disease risk actually begins at lower thresholds of systolic blood pressure as compared to men. So in this figure, what we can see is they're looking at incident cardiovascular disease risk at men and women stratified by different systolic blood pressure levels. So as you can see, we have an increase in incident cardiovascular disease risk in the women in red at this low threshold of 100 to 109 systolic blood pressure. And this is comparable to the risk that we see in men at systolic blood pressures of 130 to 139 millimeters of mercury. And so with this, it's really important that we better understand some of the mechanisms that might be contributing to this increased cardiovascular disease risk in these women with systolic blood pressures, which are below the hypertensive threshold. One potential mechanism might be impaired vascular endothelial function. As we know that this is something that both precedes and contributes to the development of cardiovascular disease. And so briefly, just what this is would be an impaired ability of the innermost layer of blood vessels to regulate vascular tone. And this is due in part to reductions in nitric oxide bioavailability, which is a vasodilatory and a vasoprotective molecule. And so one way that we can assess endothelial function in the lab is using a technique called flow-mediated dilation, which some of you may be familiar with. And so essentially what we do is we place a cuff around the lower arm just below the elbow, and then we use Doppler ultrasound to get an image of the brachial artery. And we're looking at brachial artery diameter at baseline. We'll then actually inflate that cuff around the arm for a period of 5 minutes. After that, we'll release the cuff. That will stimulate a large increase in blood flow and also an increase in shear stress along the vascular wall. That elicits an increase in the production of vasodilatory factors, including nitric oxide, which will allow for an increase in the diameter of that brachial artery. And so essentially what flow-mediated dilation is it's the percent change from that baseline diameter in response to that increase in shear stress. Where a higher flow-mediated dilation would be improved endothelial function. And so just to add one layer onto all of this is that we know that in women, vascular endothelial function declines across the menopause transition, particularly in the late peri to postmenopausal time. And so as we kind of consider the effect of different systolic blood pressure thresholds on endothelial function, we really have to do so in women across various stages of menopause. So that brings me to the purpose of my project, which was to determine if endothelial function differs across systolic blood pressure ranges below the hypertensive threshold in pre- and early perimenopausal women, as well as late peri and postmenopausal women. All right, so to do this, I did a retrospective analysis of data in 156 healthy women. They ranged in age from 19 to 70 years, and I stratified them according to menopausal stage as well as their seated clinic systolic blood pressure level. And then again, we're assessing endothelial function here using flow-mediated dilation. All right, so there's a lot of things in this table, but I just want to kind of highlight a couple things for you to keep in the back of your mind when we're looking at this data. So first of all, because this is a retrospective analysis, I do want to point out that we don't quite have equal group sizes. So for instance, we had few women, relatively few women in the less than 100 systolic blood pressure category. And then also we had relatively few pre and early perimenopausal women with systolic blood pressures in that 120 to 129 range. So just something to keep in mind. Another thing I want to point out is that, as you might expect, within a menopause stage, as we go up in systolic blood pressure level, we did see some changes in some of these more traditional risk factors. So for instance, pre and early perimenopausal women with systolic blood pressure in the 120 to 129 range had higher body fat percentages than those with lower systolic blood pressures. Additionally, and also not surprising, we did see effects of menopause stage. So an example of this is, for instance, in LDL cholesterol, the late peri and postmenopausal women had higher LDL cholesterol levels as compared to the pre and early perimenopausal women across almost all systolic blood pressure categories. This is not true, however, for all of these variables. So for instance, fasted blood glucose, there were no differences between menopause stage or across the different systolic blood pressure categories. All right, so looking at our primary outcome here, this is flow-mediated dilation. So again, a higher value for flow-mediated dilation would indicate better or healthier vascular endothelium. So looking at our pre and early perimenopausal group, we note that there were no differences in brachial artery flow-mediated dilation between the systolic blood pressure categories. However, when we're looking at the late peri and postmenopausal group, we do note that women with a systolic blood pressure in the 120 to 129 range had attenuated endothelial function compared to those in the 100 to 109 range, and also those in the 110 to 119 range. And then trying to look at this in the big picture, I kind of mentioned a couple slides ago that we had differences both in menopause stage, between menopause stages, as well as across systolic blood pressure categories. And so what we're really wondering is, apart from those differences, is there a relationship between systolic blood pressure and vascular endothelial function? And so the way that I looked at this was using a multiple linear regression analysis. So essentially what we're doing is saying, is there an effect of having a systolic blood pressure between 120 to 129 on endothelial function, while also considering these differences in traditional risk factors? And so you can see in the pre and early perimenopausal group, the model wasn't very effective in predicting endothelial function. So R squared here is 0.15. And the only thing that emerged as an independent contributor to endothelial dysfunction here was increasing age. In contrast, if we look at our late peri and postmenopausal group, the model did quite a bit better. R squared was 0.43. And we note that advancing age, as well as a higher body fat percentage, and having a systolic blood pressure in the 120 to 129 range, all emerged as independent contributors to vascular endothelial dysfunction. All right, so just to summarize, our preliminary findings are that late peri and postmenopausal women did display impaired vascular endothelial function at systolic blood pressures below the hypertensive threshold of 130 millimeters of mercury. And then next steps on this, I'm hoping to develop this into a paper. To do that, I hope to get some additional data to kind of round out our group sizes in those areas that I mentioned. I'd also like to look at different metrics of vascular health. So for instance, we probably can incorporate measures of arterial stiffness into this data set, which also contributes to the development of cardiovascular disease. And then finally, I should be able to do some subset analyses looking at mechanisms like circulating, as well as endothelial cell markers of oxidative stress and inflammation, to trying to figure out what are some of the pathways that might be leading to this endothelial dysfunction. And with that, thank you to everyone, as well as Dr. Moreau and the image group team who collected all the data that I presented.
while others wait, think about questions. So, can you clarify, healthy means that individuals were not on any blood pressure medications at all?
Yes.
For this, baseline systolic blood pressure.
Yeah, so this is a data set just combining like a big variety of studies that were conducted over a number of years. So these women are typically recreationally active, not on any kind of cardiovascular focused medications, so not on like lipid lowering medications or antihypertensives.
How does this research and this information like inform what we know about like endovascular health? Like, I guess what does this matter? I don't know how to say that another way, but like, how does this inform or like change how we think about future research or clinical care?
Yeah, I think the biggest thing, and again, I'll preface this by saying this is all kind of preliminary and we need to finish. But I think the biggest thing is that like right now, the blood pressure categories are not sex specific, right? But we know that often until midlife, women typically have lower blood pressures than men. And then after midlife, they have an increased trajectory of rising blood pressures. And then from this data, we can see there are consequences to that. And so I think the more we kind of figure out what these mechanisms are, that kind of bolsters evidence for maybe needing some sex-specific blood pressure guidance. Yeah, I think that's my biggest takeaway.
I'm really curious about hormone replacement therapy in women and these types of changes and what might be the difference there within the gender.
Yeah. So definitely I maybe can go back. When we see that the late peri and postmenopausal women, they all had lower vascular endothelial function compared to the pre and early perimenopausal women. And the major contributor, a major contributor to that is the declines in estrogen across the menopause transition. So that's definitely something that's driving those big menopause stage related differences. But whether if you do hormone replacement therapy and that, maybe brings them back up, definitely potentially. And we do have sex hormone data in all these participants, so that is to be determined.
And then maybe final questions to Claire Cox. Were there any findings that you didn't expect or lead you in a different direction than you were expecting?
Yeah, honestly, I was surprised I guess I wasn't super surprised by kind of what we're showing initially. I think one thing that I do want to look at this in men. So we can see if we see maybe there's impaired endothelial function in men at those lower thresholds of systolic blood pressure. To my knowledge, I don't know that has been done, but I think if we don't show that in men and we do show it in women, that's a powerful thing. Yeah.
Thank you. Great. So I think Stephanie,
I will need to do next slides for you, but Stephanie Hartz is our next presenter. And hopefully you can unmute and we can hear you.
Yes, can you hear me?
Yes, you're great.
Wonderful. So I'm here today to talk about our age-friendly palliative care for veterans and their caregivers within the VA Eastern Colorado healthcare system at the Metro State University Social Work Palliative Conference last month. I presented with Laura Madeline Tebow. She is the outpatient social worker for the VA RMR palliative team. And so I put some acknowledgements in the chats as there are many folks here. This presentation came from our age-friendly paper to share that here in Eastern Colorado, our telepalliative care rural and telepalliative geriatric rural programs were first in the nation to achieve age-friendly level 2 recognition back in 2021. And I say that now because currently IHI does not recognize any fully virtual programs. And so we got in under the radar. And from there, we have written a paper about the success of age-friendly healthcare systems and telepalliative or palliative care and how they are complementary of each other. Next slide, please. So hopefully folks here are aware of age-friendly health systems and the use of the 4 M's, and it does align very well with palliative care and that system. Next slide. So for an overview, the US population of folks that are 65 years and older is expected to double to 83.7 million in 2050. And so our healthcare system is not equipped to handle all of the older adults that will be walking through the doors and needing help. And from there, the John A. Hartford Foundation and the Institute for Healthcare Improvement, in partnership with the American Hospital Association and Catholic Health Association of the United States, came up with age-friendly health systems in order to address the growing older adult population. What is the goal of age-friendly health systems? It is to follow an essential set of evidence-based practices, cause no harm, and align what matters with older adults and their family caregivers. So instead of, what's wrong with you today, saying what matters to you and how can your healthcare be framed through that. The 4 M's include what matters, as I just mentioned, instead of the provider or another person saying, you must take your diabetes medication every day or apply this lotion, things like that. What is important to the patient and their family? Medication, and we know that there can be many interactions in older adults with different medications, especially when it comes to mobility. Is there fall risks associated with medication? Who is helping when it comes to med management, filling the pill boxes? So those are questions that are asked. As well as mentation, we talk about mood. Is there depression present, dementia, or delirium when it comes to different settings? The 4th M is mobility, and we talk about safety, fall prevention, making sure that older adults have the equipment that they need for safety, or is it time for a tune-up when it comes to physical therapy or other DME benefits? So there are many age-friendly programs across the country within the VA and outside of the VA. This number is growing, which is a great thing, and age-friendly can happen in any different type of setting across the healthcare system. So level 1 participant is essentially taking an assessment that a team already has and modifying it to meet the 4M framework. In my experience, I think that it's easy to overthink this and that it could be complicated, and actually in practice, age-friendly health systems is not as hard as it needs to be. And so just to highlight that within palliative care, the team is essentially already asking these questions: how are things going? And so level 1 participants modify their assessment to meet the age-friendly system requirements. And then from there, level 2 is having 3 months of data from the team reviewing how is it going, are there changes that needed to be made? And that can happen either by observing, doing a chart review, or electronic health record report. Here at the VA, since our team has become age-friendly, they now have a Power BI dashboard or visualization software to help and make it so much easier instead of hand counting all of the visits for 3 months. Next slide. Here is a poster, and I'd like to just say that this was in conjunction with Dr. Alex Garbin, Courtney McGuire, social worker, and Dr. Katie Nearing that we submitted for VA Research Days. From our paper that we resubmitted yesterday, actually, and talking about what does the process look like, or what would someone expect once a referral comes through for our telepalliative care clinic. And then we have the associated data that we saw veterans in FY23, I believe, and 24 for tracking the number that we saw and how many were able to successfully have that age-friendly health system interaction and questions. In palliative care, there are palliative care and age-friendly health systems go very well together because they are patient-focused. And using the age-friendly questions is a fantastic guide when it comes to having a palliative care conversation. What is important? What are the values? And listening to the patient so that they feel that they are driving their healthcare bus versus a doctor or specialist or other provider telling them what they think is important. And so social work and age-friendly health systems complement each other very well when it comes to this is work that's already happening. Social workers are advocating for their patients to have self-determination and let them speak what matters and what's important. And really, what matters to you or who or what matters most is a very telling question and is helpful to hear from the person in their words, and then asking that question across different settings, whether it's the pharmacist, the provider, the social worker, eliciting those responses and documenting in the medical records so that if there is something that is a concern or is important, that other specialty providers can see it as well too, with the goal that they would be able to focus the veterans' care around what's important to them. So we have some references and I would open it up to any questions. Wanted to put in the chat, we had an update to the paper title and then also some acknowledgements. There were many people that participated in the VA Eastern Colorado age-friendly health systems level 2 accomplishments through the past years. And so I wanted to make sure those folks were recognized as well.
Thank you so much. Such a great example of interprofessional care and the combination and novelty of palliative care to meet the age-friendly guidance. Others would speak.
I know for a lot of the meeting the age-friendly qualifications, especially for mentation and mobility, often people will rely on more objective measures like gait speed or doing a MOCA. With the telepalliative care program, did you use any telehealth objective measures, or was it mostly questionnaire based?
It was mostly questionnaire based. For our Geriatrics clinic. In order for veterans to come see us, we require a brief cognitive screen be completed ahead of time. And so different clinics have different requirements in palliative care. If the veterans are able to track their conversation, we have a different threshold than those when it comes to our geriatrics or dementia care team. And I do ask the PHQ-2 a depression screening so that we can also factor in mood with mentation.
How has there been opportunity for spread of age-friendly related to the fact that you have a Power BI report? It's terrific. Do you know of others seeking to use it?
I can share here that at Eastern Colorado, our outpatient palliative care team is starting their level 1 journey this year. And Laura Madeline is spearheading those efforts. There have been other areas within the VA that have embraced and started to adapt the age-friendly process. And I think the numbers keep growing because I'm VA-based. I know more about VA than I do the private sector.
Well, thank you, Stephanie.
Thank you all for, thank you to all of the presenters and great interactions and for joining us today at Grand Rounds.
So we will transition to our time, 10 minutes, and then we'll get started with division.